Hi there, my name is Will Niven. I'm a consultant in emergency medicine and I work at the Homerton University Hospital. I've put together a presentation basically looking at the critical appraisal of RCTs or randomized controlled trials and therapeutic papers. And the idea behind this is that you would watch or listen to this lecture prior to reading a couple of the papers that I will upload onto Synapse, and thereafter having a crack at reading and interpreting those papers in the light of what you've learned today. So without further ado, I think the main question that you're all asking right now is what has the randomized control trial ever done for us? Well, the answer is actually quite a lot, and it all started with this gentleman over here whose name was James Lind, and in 1747 he divided 12 sailors into 6 groups of 2, and they all got the same diet, but each of the 2 sailors in the 6 groups got either a quart of cider daily, 25 drops of sulfuric acid elixir, don't know what happened to them, 3 spoonfuls of vinegar, half a pint of seawater, a spicy paste and barley water, and then the 6th group got 2 oranges and a lemon. The fruit ran out after about 6 days, but by that time one sailor was fit for duty and the other one was almost better. He still maintained that scurvy was the result of ill-digested and putrefying food, showing that no matter how intelligent the investigator or obvious the results, people do get things spectacularly wrong. So we've moved on a bit since then, and now the RCT is very much considered the gold standard in medicine, to the extent that Sibbald in 1998 stated that the randomized controlled trial represents the best method that we have at our disposal to establish whether a cause-effect relation exists between treatment and outcome. What are some of the chief features of this? Well, they really include random allocation to intervention groups, the patients as well as the trialists and the people ideally reading the results of the study are unaware of which treatment group the patients have been assigned to. All groups are treated in exactly the same fashion, except for the experimental treatment. And there is an intention to treat analysis. And the analysis itself is focused on really estimating the size of the difference in a predefined outcome, and that's really important, a predefined outcome between the 2 groups. So we've got a number of strategies that we can use to critically appraise therapy studies, and we've touched on these before, but essentially they are the validity of the study, whether or not it's actually important, and then finally whether or not it's actually applicable to our practice. So starting at the beginning, the first question is this randomized control trial valid? And there are a couple of things which can really threaten the validity of a study, and these are referred to as, well, what I would like to refer to them as Macbeth's 3 witches, which are essentially chance, which is a problem related to a random error, and we reduce this by increasing the sample size. Bias, which is, in other words, a systematic error in the trial, and we reduce this by having a robust methodology. And confounding, which we do through randomization and distributing the characteristics of all the trial participants between the 2 arms of the study. The consult statement was derived by a number of top researchers a number of years ago, and was essentially an effort developed to help authors improve the reporting of randomized controlled trials by using a checklist. And in the left column over there, you'll see the various headings under which the consult statement essentially looks to provide a checklist in order to improve the actual content and reporting of these trials. It's not easy to do an RCT, and as you can see over here, there's fellow setting out in the bottom left-hand corner has got a number of obstacles to navigate before he actually finally gets his paper accepted. So what are the basics? Well, the basics of any RCT is that there needs to be a research question and two groups need to be compared. They should state randomization in the initial title, and the reason for this is so that it's actually properly indexed on Medline. In the mid-1990s, electronic searching of Medline yielded only about half of the randomized control trials relevant to a topic, and this deficiency has been remedied in part by the work of the Cochrane collaboration, which by 1999 had identified almost 100,000 reports of trials that had not been indexed correctly on Medline. The reports have now been re-indexed, and adherence to this recommendation should improve the accuracy of indexing in the future. So here's an example of a paper that I'm going to upload shortly onto Synapse, and it's essentially a randomized control trial that compares the use of absorbable versus non-absorbable sutures on the extremities and trunk. It's by Tajani et al. In Academic Emergency Medicine. Moving on from the title, we then get on to the introduction, and really you should have a fairly clear idea by the end of the introduction of why the study was done. It should outline a clear topic within the first sentence. It should give the context of previous research. Is there a gap? Are there some unanswered questions? What's the scientific background for the question? And what previous work has been done? What were the flaws? What's different about this study? Ideally, it should also have some of the relevance to emergency medicine or whatever particular research field it pertains to. And then there should be some clear aims and objectives. You then move on to really two kind of main questions that you need to be asking about whether you should read the rest of this paper. And the first one is, does it ask a clearly focused question? And that is classically a PICO question. So P standing for population, I for intervention, C for control, and O for outcome. A lot of people add T at the end of that PICO to make PICOT, T referring to a time period, or is it time bound? And then the next question is this a randomized control trial? And if yes, is it appropriately so? Why was the study carried out as a randomized control trial? And is it the right research approach for the actual question being asked? We then move on to the methodology, and this deals with recruitment. How were the patients actually recruited into this trial? Were they randomized to different groups? Was there concealment of that allocation process, of that randomization process? Who was blinded? Were patients blinded? Were the researchers blinded? Were the people reading the results of the trial or treatment being tested blinded as well? Was there an objective outcome that was stated a priori? In other words, before they'd actually started recruiting? What was the follow-up like for all the participants in the trial? Was there an intention to treat analysis performed? And we'll get to explain that a little bit later. And what were the measures of effectiveness used? So essentially the methodology is a bit like the main course. Without it, the whole paper is going to fall down. And for those of you that are into vegetarian food, I've put some halloumi there, just so as not to be overly biased towards meat eaters. So, looking at the recruitment process, they need to identify the setting and the source of the recruited patients. So, in the context of this particular paper, it was 2 urban inner city hospital ED departments, and the population that was studied were both children and adults. They need to set out really quite early on who was included in the study and who was excluded, and whether or not consent was provided. So if you look on the right column over there, basically I've outlined how the authors in this particular case delineated who was and who was not included. So randomization is a means of ensuring that confounding factors are equally distributed between the groups that are being compared. So randomization ensures that the two groups are as similar as possible and that the only difference is the intervention that's being made in the trial. Bias may result if patients, carers, or researchers can influence allocation. For example, patients may choose a treatment that they think will be beneficial. This will result in certain types of patient being allocated to certain treatments, leading to bias. The more that patients, carers, and research can influence allocation to treatment group, the greater bias is likely to arise. This bias may be known as allocation bias or selection bias. So there are a number of different types of randomization, and ideally participants should be assigned to comparison groups in the trial on the basis of a chance or randomized process characterized by unpredictability. So authors should provide sufficient information that the reader can assess the methods that are used to generate the random allocation sequence and the likelihood of bias in group assignment. Many sequence generation methods are adequate. However, readers cannot judge the adequacy from such terms as random allocation, randomization, or random without further elaboration, and authors should specify the method of sequence generation, such as a random number table or a computerized random number generator. There are a number of different ways that you could randomize. You could potentially toss a coin, but using days a week probably wouldn't work, though people have used it in the past before. And the reason for that is that if you allocated, treatment group to Monday and control group to Tuesday, then both patients and researchers would know which treatment the patients had been allocated to, so that would defeat the purpose. Time of day, exactly the same argument. A randomized number table, as we've said before, is a really good way of doing it. Hospital number, date of birth have exactly the same problems that day of the week and time of day could have. And the classic method that's generally used is the telephone randomization hotline. So in this particular paper, they state, using a random number generator in blocks of 10, the number of suture types were placed by an independent physician in sealed consecutively numbered envelopes. After identifying an eligible patient and obtaining informed consent and assent, the physician who enrolled the patient picked up an envelope. So I think that's pretty well described. So what I'm going to try and do over here is explain what happens in block randomization. Now what you'll see there is you've got randomized with a seed of 10 and subjects 20. Now what that essentially means is that for treatment A and treatment B, there are an equal number of A's and B's. So they're 10 A's and they're 10 B's. When it says block size random between 4 and 8, every 4 patients or every 8 patients, you're going to have exactly the same number of A's and B's within within the block of 4 or within the block of 8. And the main reason for doing this is that you may have a relatively small number of patients that can be recruited into the trial. And what you don't want to do is, if you were flipping a coin, by chance have 15 people that were allocated to A and 5 people that were allocated to B. So randomizing in blocks ensures that you get an equal number of patients allocated to the treatment and to the control arm. So allocation concealment. So essentially what this means is that the allocated group is not revealed until the patient is irreversibly entered into the trial. And what that does is that it protects the randomization sequence and avoids selection bias before and until the actual allocation to the treatment or to the control arm. You can do it by a telephone randomization hotline, or you can do it by sequentially numbered envelopes. It's been shown that inadequate concealment can overestimate the treatment effect by as much as 30%, so this is a really important part of randomized controlled trials. Blinding. So blinding actually happens after they've been randomized, after the allocations have been concealed. The blinding actually happens. So you can have patients, you can have carers, you can have researchers, you can actually have the people reading results at the end being blinded. It's not always completely practical. As I've said, it happens after the allocation. potential for lack of blinding can lead to bias depending on the outcome being measured. So if people are not blinded to the treatment they're receiving, they think that it's a new treatment, they may overestimate the effect. And if you've got researchers that are really keen on showing that a new treatment is good or better than the index treatment or control, then you may once again get them overestimating an effect, and that's just unfortunately part of human nature. It's not always possible, as you can see perhaps in this trial over here, whether someone uses absorbable or non-absorbable suture becomes pretty evident by the time you've actually opened up the suture material pack. But what you can do is you can randomize and conceal the suture material prior to the actual laceration, but when the person's actually been allocated to the treatment or to the control arm. So in this particular example, they say the photos were then rated for the primary outcome of cosmesis by 2 plastic surgeons who were blinded to treatment allocation. Now this is quite interesting because whilst the actual people carrying out the suturing were not blinded to the material they were using, the people that were actually looking at the scar several months down the line were in fact blinded and had no idea whether they were using absorbable or non-absorbable suture on the particular wound in question. So just a little word about outcomes. There should always be a primary outcome stated, and we really want to see something pretty explicit. We don't want to see the outcome changing, and as we've seen before in various trials, including the very prestigious IST3 stroke trial, the outcome changed halfway through the trial. So the outcome needs to be explicitly stated right at the beginning in the introduction, and it shouldn't change at any point. So in this particular case, the primary outcome was 2 plastic surgeons' opinion on the overall quality of the scar a couple of months down the line. In this case, there was some secondary outcomes, which they looked at, photographs were evaluated for the secondary outcome of train tracking, and secondary outcomes add a little bit of granularity and a bit more of an idea of they add a little bit of a complexion to the primary outcome in question. The issue with secondary outcome is that the study may not actually be powered to detect a difference for the secondary outcome. We'll talk a little bit about power in a bit. And ideally, there should be a good range of secondary outcomes to address the different objectives. Sample size is done to mitigate against chance, and this reduces the chance of you making a type 2 error, which is when you say there is no difference between treatment and placebo when there is in fact one. And the sample should be large enough to detect any difference should one exist. The clinically important differences is determined by the researchers. So for example, if you said that a difference in blood pressure of 10 systolic was significant, that would make sense. If it was 2, then it probably wouldn't make much of a difference. If it was 2 systolic, then it wouldn't make much of a difference if you were evaluating a new antihypertensive drug. And then you do a power calculation to determine the power size. So in this particular example over here, there are really a couple of things that you need in order to make a sample size calculation. So you need to know the standard deviation for standard deviation. You need to know the type 1 area. You need to have a power, set of power, which is normally set at 80 or at 90%. And then you need to know what the minimum clinically important difference, or the MCID. All patients should ideally be followed up and have the outcomes measured at a number of different times, and you need to know how many were lost to follow-up and was there a marked difference in attrition rates between the two groups. And this leads us on to the intention to treat analysis, which has been essentially simplified into analyze as you randomize. So patients should be analyzed in the group they were initially randomized to. If patients are allowed to leave the group to which they were analysed, this will introduce bias. So patients who withdraw, do not attend follow-up, fail to comply, or have to change treatment because of adverse effects will be different from those who complete their treatment as allocated. Therefore, all patients should be analysed in the group they were originally allocated to, regardless of the treatment that they ultimately received. So we've discussed the validity, we've talked about of the trial. Clinical importance is the next thing that we're going to talk about, and we'll eventually get on to applicability. Results deal with the clinical importance of the trial in question. Here is an example of a consort diagram which essentially kind of maps the movement of patients through the trial. You will then normally get a table like this, which is often one of the first tables in the results section. As you can see on the left column over here, they've got various things such as age, gender. They've got some of the characteristics of the lacerations in question, and then as you move to the right, you can see a bit more kind of granular. You've got a bit more information on who was lost to follow up and whether or not there were significant differences between the two groups. So what I've got over here is perhaps one of the most important statements from the paper in question, which essentially says that the difference between the two scores was 0.5 millimeters, and then they give you a 95% confidence interval of minus 12.1 to 17.2. And essentially because the absolute value of the lower end of the confidence interval was below that was set up in the initial primary outcome of 13 millimeters, they've made a conclusion that vical repeat is not necessarily inferior to proline for suture repair. That segues on to measures of effectiveness, and there are really two things that you can use. You can use a p-value, which will tell you whether or not there's a statistical significance between the treatment or the control arm, and then a 95% confidence interval, which has the benefits of giving you an upper and a lower limit. When we talk about measures of effectiveness, we, within the context of RCTs, we really want to know how much better one treatment is than the other, and we've got three basic means of doing this. One is absolute risk reduction, the other one's relative risk reduction, the other one's number needed to treat. So absolute risk reduction is what is otherwise known as the control event rate minus the experimental event rate. So if 20 out of 100 people die in the usual treatment group and 15 out of 100 in the new treatment group, then the absolute risk reduction is 20 minus 15, which gives you 5%. And absolute risk reduction takes the baseline event into account, baseline event rate into account, and is probably more useful to the individual patient. Relative risk reduction, by contrast, is really beloved of the industry, and what you essentially do with that is that you divide the absolute risk reduction by the control event rate. So what that does is that it essentially gives you if 15 out of 100 die in the treatment group versus 20 in the control, you divide 20 over 100 minus 15 over 100 by 20 over 100, and then you get a 25% relative risk reduction, which obviously sounds a lot more sexy than 5%. So it's a good measure for determining the strength of an effect, but it's really of quite limited use when you're talking to the individual patient. So number needed to treat is the inverse of the absolute risk reduction. So if 15 out of 100 people die in a treatment group, 20 out of 100 in the control group, you subtract 15 from 20 to get essentially 5 or 0.05 if you're going by percentages, and then you divide 1 by 0.05 to get 20, so you need to treat 20 people in order to avoid 1 death. Moving on to the analysis and discussion, that's the dessert part of the randomized controlled trial appraisal process. And really what they should do is they should summarize the key findings. They should provide an explanation for why they think they got the results. Again, this is a bit like with the introduction. It's a time to compare and contrast with the literature that's already published on the particular subject. You then would expect them to put in the limitations of the study, and that could be anything from methodological flaws to issues with generalizability or external validity. And then there should be some kind of discussion about whether the results that they found are actually clinically important or whether they're just statistically significant. So in the context of this particular paper, there was a very high dropout rate. So 40 dropped out of 127 patients. That's really pretty impressive. You also found that those people that dropped out of the study tended to have much longer or bigger lacerations, and you might want to ask some questions about why that actually happened. And then they've said our study lacked the power to detect significant differences with respect to complication rates, which is the kind of information that you probably want to know if you were going to go all out for an unabsorbable over an absorbable suture as a standard kind of practice for your patients in an emergency department. So once again, we've gone through the validity, we've talked about clinical importance. We now really need to know about applicability. Does this study actually apply to my context? And here are some of the important considerations. Does it make sense to change practice in line with this study? The price for is £53 for 12 Vicryl versus £28 for 12 nylon filaments, so almost double the price. What will the impact on the department be? So, will people feel comfortable using a new suture material? What is the impact on the patient? So, one would have thought that if a patient had an absorbable material, that them not having to come back to have sutures removed might actually be quite convenient for them. But after we've appraised the study, we can see that we don't really have much information on the complication rate, and we don't know what happens to larger lacerations. So there's not really much we can actually provide to the patient in terms of high quality evidence for absorbable versus non-absorbable sutures for their laceration at this particular point. The context within which the research was conducted matters. So a study that was conducted at the Mount Sinai Hospital may have been carried out absolutely perfectly. There may have been no protocol violations, and the overall internal validity of the study may be really good, but it may not be generalizable to a rural African setting, and it may not necessarily even be generalizable to a different country, or where the modus operandi for anything from imaging through to suturing through to various forms of therapy may be different depending on various other things, such as precedent, budgetary constraints, or the preference, or even something as arbitrary as the preference of the consultant that was there 15 years ago. So there are some problems associated with randomized controlled trials. They're not powered to detect all outcomes, as we've talked a little bit about. They're not always powered to detect secondary outcomes, so that can be a problem. They're very expensive, so the only people that actually necessarily have money for them is often the industry or the pharmaceutical industry, which introduces another form of bias. They take a really long time to perform, and unfortunately their findings are often overturned a few years later, up to 50%, according to a recent review. So, for example, the evidence is far from complete regarding thrombolysis and acute ischemic stroke. Tranexamic acid has been shown to be of major benefit in trauma, but recent, as yet unpublished research suggests that there is an increased thrombotic rate in those who've received it, something that should be obvious but was not the focus of the original CRASH 3 study. And there are charlatans out there that have either obvious or concealed conflicts of interest, as in the case of Andrew Wakefield and the MMR debacle. So in summary, what we're interested about in RCTs is how the patients were selected, and that's recruitment, how they were allocated to the treatment group, that's the randomization. Was their allocation actually concealed? Were patients, carers, researchers blinded? What were the outcomes being measured? Was there an intention to treat analysis? How adequate was the follow-up? and what was the treatment effect? Are these results important, and is it applicable to my practice? So thank you for listening to this lecture. I'm going to post the article in question on the Synapse website shortly, as well as the paper that I would like you to read before we have the core academic day on the 21st of June. I'll post my email address on the Synapse website, and I would welcome your questions prior to the core academic day itself, and I'll endeavour to get back to you before the day kicks off. Thanks very much.